This session was laid on fairly recently, so those of you that have come, I appreciate it. And I'm looking forward to having a chance to kind of give you at least a little window into a way of looking at healthcare, both in advanced economies as well as in developing economies that hopefully will kind of stretch and pull and prod your perspective and your thinking. This is, as all of you know, healthcare is a really important, really complicated, really complex subject. One can spend a whole career on one little piece of the problem or of the issue of healthcare. But what I've tried to do is something perhaps foolhardy, which is to try to come up with really a fully systemic view of the question of healthcare delivery. And the kind of central phrase that tries to capture that is the notion of value-based healthcare delivery. And I'll talk a little bit about what that means in a minute. What I'd like to do is start by giving you a bit of an overview of the kind of basic concepts that underlie this body of work, and that'll take hopefully not too much more than 15 or 20 minutes. Those basic principles really apply in any setting, advanced economy, developing country. These are what I consider kind of underlying principles. And then I'd like to take the second part of the broadcasting portion of this session and talk about global health. Not out of being a deep expert in global health, but I have spent the last 3 or 4 years getting fairly deeply involved in global health delivery systems. And there's a whole project at Harvard called the Global Health Delivery Project, which involves many folks, most of whom are in the School of Public Health and the medical school. And I've been trying to help work with that group on this topic. So I'd like to give you a little bit of a flavor for what that work is starting to reveal. I'd also like to, I think my number one job today is to get you to actually look further. We're not going to be able to cover today the richness of this topic, but hopefully I can get you intrigued enough that you'll look at some of the additional books and articles and case studies that are growing out of this work. That's really the goal today. It's to kind of motivate you to dive in further. So how do we think about healthcare really from a holistic perspective? How can we sort of start to get on a different path in terms of breaking through this challenging question of reforming healthcare? Well, I think at least our point of view is that the starting point for any ultimately successful healthcare delivery system is universal access. We can't ultimately succeed in healthcare unless everybody gets healthcare, unless everybody has access to care. So I want to go on record and say we believe in universal access. We believe that is a fundamental goal in healthcare. A lot of other countries have actually achieved universal access. We haven't in this country. But really, our ideas really start from the perspective that's just the beginning. And as hard as access is, it's not actually, in a sense, the fundamental problem. The fundamental problem in healthcare is actually the value of the healthcare that we actually deliver. It's not getting people covered and spending money. It's actually what we get for all the investment that is being made in the actual delivery of care. And the fundamental question is how to dramatically improve the value of healthcare delivered. Value being defined as the patient health outcomes per dollar spent. Patient health outcomes, how well the patient actually does, what health they're able to achieve and sustain, and then the per dollar spent is the cost involved in actually delivering those outcomes. And we believe that value then becomes the central fundamental goal that must guide any progress in truly reforming and improving healthcare. We've got to improve the value. We can't just provide access. We've got to fundamentally improve the value. And so the quest that we've been on is how to think about a healthcare delivery system that would maximize the value and keep improving that value over time. What would that kind of system look like? What would its essential components be? What are the kind of underlying principles that would guide the design of a high-value delivery system? That's the real question that I'd like to talk with you about today, first in general terms, and then in terms of thinking about global health in resource-poor settings. Now, in order to create a high-value healthcare system, I think the first kind of chasm that you have to confront is the chasm that we can't do it incrementally. The problem with healthcare delivery is that we have to make fundamental structural change. We can't just make incremental improvements on the system we have today. How do we know that? Because we have been making incremental improvements over the last 10 or 20 years, and those incremental improvements haven't really made a big difference. In fact, they have made almost no difference at all. The problem we have is the current structure of healthcare delivery, and I'll talk about structure a little bit later. The current structure is a legacy structure that we've inherited from bygone years in a very different context. 30 or 40 years ago, there wasn't much we could do in terms of healthcare. There weren't many drugs. There weren't many procedures. There was very little technology. 30, 40, 50 years ago, mobility of individuals was much more limited than it is today. And that's one of the reasons why we have such a local model of healthcare, where the presumption is that you will go to your local hospital and that local hospital will take care of you. In that earlier world, the structure we have today, kind of made sense. The structure that we have today is also a reflection of how physicians and medical personnel are trained in specialties, in silos. And again, one understands why we have that structure. But what we've come to believe is that if we don't change that fundamental structure, grafting on incremental improvements and patches will not ultimately produce success. What's an example of an incremental improvement? Well, here's just some of them here on this slide. We have all kinds of safety initiatives and care pathway projects and disease management overlays. Many of them have produced very disappointing results. The reason is that if you don't change the basic structure, how you organize care, who works with who, how they're paid and how they're motivated, actually adding these patches will not ultimately succeed. Nor can, unfortunately, we delegate to the consumer the transformation of healthcare. We've had this consumer-driven healthcare movement. Of course we want to have informed patients, and of course we want patients to be engaged in their care, but the idea that if we just make patients pay more money, they'll somehow magically transform the healthcare system is a completely unrealistic. It can't happen. Patients can't coordinate their own care. Patients can't overcome a dysfunctional system. So fundamentally, the challenge then is how do we create a vision for what kind of a structure would actually deliver a high value? And then we can make incremental improvements, but at least we're making incremental improvements towards a kind of a fundamentally robust long-term strategy. And that, I think, has been one of the problems in healthcare reform for these many, many years, is that we've really not understood what we're looking for, what the ideal would look like. And therefore, we've been kind of making incremental improvements based on where we are today. The final thing that is a very important part of my work on healthcare, given my background as a strategy professor and a competition expert, is what's the role of competition in the healthcare delivery system? And when you use the word competition in healthcare, there's a certain percentage of any audience that just kind of goes, ugh, that's that's wrong. We shouldn't have competition in this field. This is not a field where competition will work. I understand that reaction because competition has been very ugly in healthcare. Competition has actually probably made the system worse rather than better. What's the problem? And the structure of the system that we've inherited. We have a system today where the financial success of system participants is disconnected from actually the success of the patient. If a provider gets paid more for doing more stuff, if a provider gets paid more for doing complicated stuff than simple stuff, then we have a disconnect between what's in the interest of the provider and in the interest of the patient. Not that physicians don't regularly, for professional reasons, do the right thing, but we're creating a disconnect. When health plans can make money by selecting out sick people and passing costs to the consumer and higher deductibles, and that's a way that they can succeed, that actually doesn't actually benefit the patient at all. We have a lot of competition in healthcare, which is what we call kind of zero-sum competition. It doesn't create actually value for the patient. And one of the fundamental challenges in healthcare is to align competition with value for the patient. And so the question is, how do we actually do that? Choice is good. Competition is good. It should help us more quickly get to where we want to go, but we've got to change the nature of that competition at a very basic level. So how do we actually think about a high-value healthcare delivery system? Well, let's get at some of the really critical principles. First of all, what does value really mean? And here, value, when we talk about value, we're talking about really the full set of patient outcomes over the whole care cycle for their medical condition. So say you've got a patient with cancer. When we're talking about outcomes, we're talking about how well that patient does looked at over that whole process of care. Not just the outcome of a particular procedure or a particular inpatient stay or a particular episode in the longer care cycle. So one of the problems we have today is, to the extent that we do measure, we measure too short an increment in the care process. And therefore, we're not really measuring the full, true outcome that we really care about. On the cost side, costs are the total cost of care for the patient's condition, not the cost of the individual interventions. One of the fundamental problems in healthcare today is we focus too much on the individual interventions and trying to beat down the cost of those, rather than think about the total cost of the full set of interventions. And in global health, this is very vividly important. But it may be that we want to spend more on certain kinds of counseling and visits, because then we'll save money later on because we won't have the emergency room visit or the hospital admission. We can't think about the cost of each service and just think that cost is the sum of all those costs. We've got to think of cost as the kind of systems cost of really the whole cycle of care. Again, this is a fundamental point in global health as well, and we'll come back to that in a minute. So the question is, what are the key levers, what are the key choices that we make in order to maximize the value? How do we think about that? Well, in order to maximize value, the first thing that I think we discover from really looking at the literature and also just common sense is that if you're trying to drive up value, really the most powerful way to do that is to work on the numerator, not the denominator. To actually drive up outcomes rather than get preoccupied with cost. And of course, what we've been preoccupied in healthcare lately, we define the problem as it's too costly. And therefore, a lot of the efforts have been on cost control. How can we reduce the number of images ordered? How can we, kind of avoid the wasted cost, rather than ask ourselves the question, what do we need to do to really drive the outcomes up? And the reason that driving outcomes up is so important is because, of course, outcomes are what we all care about. How healthy did we get? How much of our health was retained or renewed? But we also, by improving outcomes, we actually fundamentally reduce cost in the long run. The only way to really reduce the cost of healthcare is to improve the outcomes. You can beat down the cost of providing services, but that's never going to ultimately be the road to success. The way to actually reduce the cost of healthcare is to actually detect diseases early so you can deal with them more efficiently, get the right treatment to the right patient. Many cancer drugs, 10% of the patients respond. It's not the price of the drug, it's getting the 10% up to 20% or 30% or 40% response rates. It's treating earlier in the cycle of disease. It's getting the treatment to happen quickly so you don't stretch it out, because time is money in terms of the cycle of care, and so on. Again, we have a lot of people in healthcare that think that good quality is expensive, that to get an excellent quality you should pay more, and that's absolutely Alice in Wonderland. Good quality is cheap. you shouldn't have to pay more for high quality. Actually, the people that deliver high quality will actually make more money because they'll be much, much more efficient. And there's copious evidence of this. And yet we all think that technology is the enemy, and that's what's driving up the cost, and it's distracting us from what really needs to be done. We haven't today engineered our healthcare delivery system around outcomes. And Exhibit A is that we just don't measure outcomes. How can we have a healthcare system that delivers good outcomes if we don't measure outcomes? And this is kind of one of the central pillars of what has to happen in any healthcare delivery system is it's going to be successful. So as we're going to try to drive value, we have to focus on the outcomes, not just on the cost. Now, to make a very complicated story short, in order to sort of create a high-value delivery system, when I talk to a management team of the Cleveland Clinic or the Mayo Clinic or any other delivery organization, basically there are 6 fundamental agendas in restructuring delivery around value. So let me give you just a little tiny bit of sense of what each of these agendas are and why, and then we can kind of talk a little bit about how we can apply the same thinking in the context of global health. The first agenda, and in some ways the most complicated, is actually to organize care around the patient, not around the specialty and the service being provided. And this is the concept which I call integrated practice units. And so let me try to, I'll describe that a little bit later. Now, the integrated practice unit concept, where we integrate care around the patient's needs, applies, of course, very clearly to specialty care for cancer care or diabetes care. But we also find that the same principles are fundamental to really improving the care, primary and preventative care. Except here, the kind of central organizing principle is not the patient's medical condition, but actually the patient population that we're trying to serve. And I'll come back and talk about this a little bit later. Number 2, we have to learn to measure outcomes and cost for every patient. Right now, we rarely do this, and on the cost side, I know of not a single hospital in America that actually can measure the total cost for an individual patient. When you talk to today's healthcare delivery organizations, they can't measure costs. What they can measure is charges. They know how much they bill. They don't know how much it really costs. And they can accumulate costs for an individual patient. They can calculate an average cost for all patients, perhaps for the operating room time, but they can't actually figure out how an individual patient's cost was accumulated. And that means that we lack the really fundamental insight with which to really drive value. Number 3, we have to change the reimbursement model around what we call bundle reimbursement. Think of bundle reimbursement as a total medical condition. And then let the experts decide how to use that pool of money best to actually deliver the care. Rather than the system we have now where we decide how much each service is worth and then we pay based on how many of those services are provided. The current system is really misaligned with value for the patient. The bundle model actually is the way to create the best possible incentives for everybody to deliver the highest value. Fourth principle, today the delivery organizations are basically confederations of standalone, largely separate units. If you go to the Mayo Clinic and you're standing in downtown Rochester looking out over the horizon, you will see that there are other hospitals owned by the Mayo Clinic that are regional community hospitals. But even at the Mayo Clinic, those regional community hospitals that are owned by the Mayo Clinic are completely separate. They do their own thing. They have their own departments. There's no connection between the community hospital and the downtown hospital. That is very typical in healthcare delivery. We have a lot of little standalone institutions that all see their job as providing pretty much all the same services to their local community, and that model is guaranteed not to allow a high value of care. Number 5, we need, instead of having locally constrained organizations that provide services only in one region or one town, we have to have excellent organizations that can then spread service delivery across large swaths of geography. Again, the healthcare industry is really an outlier. It's been crafted in this local model where every community has its own community hospital and maybe some academic medical centers. And each of those is basically a completely separate unit. And and even if they're owned by the same entity, they're still completely separate units. We have a vivid case in Boston. We have Partners Healthcare. Mass General, Brigham and Women's are part of the same organization. They're owned by the same organization. They're completely separate. They don't talk, they don't collaborate, they don't integrate. Everything's local. And yet what we need to have is we need to have our excellent organizations not just serving patients in one town or one region, but spreading their excellent services across many regions. And that's something that's not happening in healthcare today, but it can happen in the future. Final kind of agenda has to do with IT. All of you know, of course, that information technology and electronic health records are really critical to driving value. Because that's what allows integrated care. That's what allows all the people involved in the care of a patient to have the same information and to not duplicate information and to be able to communicate seamlessly with each other. We kind of understand that IT is fundamentally important, but we are still far from the place where we have IT systems that really enable high-value care. So we'll talk about that perhaps a little bit if we have time in a moment. These are fundamentally then the 6 agendas that underlie the transformation of healthcare around value. Let's talk about each of them just a bit, because I want you to get kind of an intuition. You know, what I've come to understand is that healthcare delivery is not fundamentally a medical problem. You know, there's a lot of great medicine. There's a lot of great technology. There's a lot of great ideas and treatments, and people in this field are smart. People are hardworking. They try hard, they're dedicated. It's not about medicine, it's about organization. It's about management. This is a management problem more than it is a medical problem. We have more medical science now than we know how to deliver effectively and efficiently. And the medical part continues to surge ahead. We have all you bright people doing more lab research and coming up with more treatments and protocols, and yet we can't even deliver excellence systematically across the system. So all of you in this field have to learn some management. You don't have to go to business school, but you have to learn some management. You're trained, though, in silos. You're trained to understand your field, your specialty, your intervention, your part of the system, more so in medical school than in public health. What we need to do is we need to get all of you to understand not just your part, but how the pieces fit together, how the dots connect. How what you do connects to how all the other people do in the case of serving a given patient's needs. That's the fundamental challenge I find in the healthcare field. Healthcare has kind of grown up with a certain sensibility and a certain style of research and a certain model of training, and a lot of that's good, but it's also holding back the kind of structural change that's necessary to significantly change the value equation. So to illustrate kind of integrated care, let me use the case of migraine. Migraine is a complicated disease to actually manage well. And the case here is a case that we teach at the school on migraine care in Germany. The reason I use this example here today is because Germany has universal insurance. You know, everybody in Germany has access to care. Everybody can go to any doctor they want. It's a good insurance system. But the delivery of care is deeply short of the ideal. And migraine care is a particularly good example in Germany of care that everybody agreed was really substandard. The data on migraine care in Germany was very consistent. The care is lousy. Many patients aren't getting the right treatment. There's a lot of emergency room visits. There's many, many days off of work. There's repeat visits to the physician because the patient is their migraines are not being controlled. All the metrics that you would measure outcomes of care with were really awful. And in this particular case, a health plan was the catalyst to do something about it. Now, that is a shocking development for those of us in the United States. In the US, the health plans have not been really catalysts for very much good. about healthcare delivery. They've been really the retarding force because of the kind of legacy approach to competing. But in Germany, there was a health plan that said, gee, we've got a lot of these patients. They're relatively young. They're otherwise healthy. You know, but their disease is not being controlled, and they're having to go to the doctor over and over again, and they're going to the emergency room, and they're going into the hospital, and they're not showing up at work, and we've got to figure out what to do. So the health plan found some really interesting providers, in this case a neurology department in the town of Essen. Some of you know Essen, and started a revolution in migraine care in Germany. Now, the traditional model of migraine care looks something like this. You can see that each of these bubbles is a specialty or an intervention. There's a primary care physician, a neurologist, and so forth. And the way healthcare delivery today is organized, virtually everywhere in the world, and I've now worked in many countries, it's organized around these bubbles. And the patient is a ping pong ball. The patient is kind of ponging from bubble to bubble to bubble to bubble to bubble, okay? And often back and forth and back and forth and back and forth. What is the sort of key characteristics of this process? Number one, it's a sequential process. The patient goes to one bubble, they do something, then the patient makes an appointment and goes to the next bubble, and they do something, and then the patient goes to the next and the next and the next. And if the patient isn't doing well, then they go back to a bubble, and so on and so forth. Each bubble has its own administrative structure. So you have to make an appointment with each one separately. And that is incredibly costly. The administrative costs in healthcare are not fundamentally because of the health plans. So I'm going to be say something nice about health plans. The administrative costs of healthcare have to do with the way that doctors are organized. Because you need 7,000 appointments to go through your cycle of care. And we'll see later, an excellent care delivery organization, you'll have multiple appointments all made at the same time by one organization. They'll kind of schedule the whole process for you. And the administrative costs are very, very low. Okay? What else about this process should we note? The next key point about this process is that every one of these bubbles sees a lot of different patients for a lot of different things. So the primary care physician, has 2,500 patients in their roster, okay? And those 2,500 patients have every possible combination of issues. And that primary care physician is supposed to kind of figure it all out. The neurologist sees tons of neurological conditions. So they'll have patients coming in with MS, and they'll have people coming in for stroke issues, and they'll have all kinds of issues. And that neurologist is going to sit there and have to see, one after another, patient after patient, with all these many, many different problems. That imaging center is going to see scans from all kinds of different issues. There'll be head scans and arm scans and shoulder scans and knee scans, and they're going to have to kind of sort through and deal with all those scans and read those scans appropriately. Okay? The odds that you, the patient, will get to an individual that is genuinely an expert on your problem is very low. Healthcare is a game of a pickup team. You get who happens to be on the schedule. You get who happens to be there, not the person who's an expert or really interested in whatever problem you particularly have, except in exceptional cases. Is the neurologist interested in migraine patients? Maybe not. Maybe, but maybe not. Some neurologists think that migraine patients are neurotic women, who can't deal with life, and so they have these headaches and they show up all the time. Literally, across physicians, there's tremendous variation in expertise and interest and commitment to this particular disease. But the way the current system is set up, you get kind of who's there. You get a neurologist, and that neurologist may or may not be interested or particularly excited about treating your case. Okay. That model is guaranteed to deliver low value. It doesn't matter how smart the people are. It doesn't matter how hard they work. It doesn't matter how committed and passionate the people are on that. They can't deliver value. Why? Because they're not organized to deliver value. Because they're not focusing on doing a set of things that they can learn how to do really, really well and really, really efficiently. So what did the Germans decide to do? They decided to create something called the West German Headache Center. What's the West German Headache Center? Very simple. It says, let's not do the bubble thing. Let's put the experts that are necessary and the expertise necessary to deal with migraine in the same organizational unit. They work there. They go there every day. They have offices next to each other. And they only deal with headache patients. That's what they do. And they're people that are committed to becoming masters of dealing with headaches and migraine patients. Okay? Now, if those patients need to go into an inpatient unit for detoxification, then they're going to go next door to a neurology unit that's staffed by the same physicians that are staffing the migraine center. So there'll be a seamless transition between the outpatient care and the inpatient care. If they need to get an image to rule out a bad cause, for the migraine, then they're going to go get an imaging unit, but they're going to go to an imaging unit that develops a depth of expertise in looking at scans, the type of scans that these patients need to be analyzed. The headache center will go through a structured protocol. It will be all the appointments you need will happen simultaneously on a single day or 2 days. There'll be a structured, sort of integrated process of dealing with these patients' problems. Once they get sort of stabilized and once they have a good therapy and once things seem to be clear, then that patient will be referred out to an outside neurologist to monitor that patient. But it won't be the random neurologist. It'll be a neurologist that's actually affiliated with this center, that shares a common medical information system, that has the strong relationships and training and common expertise and guidelines and protocols. Okay? Now, what do you think happened when the West Germans went from this model to this model? Well, you probably would guess that the outcomes dramatically improved. Instantly. I mean, within a week. The number of patients having emergency room visits went down dramatically. The number of patients reporting that their disease was not well controlled and they weren't satisfied with their disease control went down dramatically. Over time, it became clear that the number of hospitalizations and emergency room visits and repeat visits went down. Outcomes went up instantly. Why? Because people that were really dedicated and focused on this disease were actually dealing with the patients, not who they kind of randomly found, through the process. Then what was interesting is, after about 6 months, the costs actually were higher. The reason is that many patients that were doing poorly would just suffer, and they wouldn't go back and have those extra appointments. They would just suffer. What this model did was it provided a lot of services up front. The patient saw the neurologist, they saw the physical therapist, they had psychological counseling, they had review of all their medication history and all that sort of stuff. That cost more than just going to the primary care physician and having your 15-minute visit. This was a more extensive investment. For the first 6 months, even though they had some improvements in cost because of reduced emergency room stays, the net cost was higher. But as of today, which is about 2 years into this particular experiment, this model is actually 25% less costly than the model was before. So here we have the great promise of healthcare reform. The promise is that we can have dramatically better outcomes, but by taking an integrated perspective, by getting the patient to people who are really expert and who have the experience and the expertise and the efficiency of dealing with that particular patient's medical condition, we can have this wonderful outcome, better outcomes, but costs will actually be reduced as well. This is the transformation necessary in healthcare delivery. We've got to stop organizing around the physicians and the services and the tools, and we have to start organizing around the patient and the patient's medical condition. And we now have a tremendous body of evidence that about organizations that do this and how tremendously they're able to transform the value equation. But it's complicated because most of these people, don't work with each other, and the traditional model puts them in separate departments, and they have separate department and division chiefs, and they get paid separately. This model involved a bundled payment. The insurance company gave the headache center a certain pool of money to care for these patients and said, you figure out what the best use of resources is. Again, making the transformation from here to here is something that is already happening, but it's going to take time, and it's going to take, I think, a growing understanding among people in the field about what the fundamental problem really is. Another kind of key idea in value-based thinking is the notion of the care delivery value chain. The idea is when we care for a medical condition, we're not only providing a lot of services at a given point in time, but there's really a whole cycle of care, a longitudinal process in which we're providing a set of services across time. And not only do we have to integrate at a given point in time, get the right skills together, but we've got to integrate across time. And we need to create organizational units that manage this whole process, rather than organize, again, around the individual discrete services or specialties. Again, we'll see this a little bit later. We can apply the same thinking to HIV/AIDS or to drug-resistant malaria or maternal and child health. We've got to start thinking holistically and systemically about the cycle of care and the set of activities involved. The big problem in medicine I found, coming from the outside, is medicine is really kind of locked on an intervention perspective. The focus is on interventions. It's on the drug or the procedure or the scan or the particular discrete intervention. That's the way people are trained. That's the way clinical studies are done. We're focused on the intervention. We're not focused on value, which is the set of interventions that have to take place over time that are mutually dependent. In breast cancer care, it's not just what you do here that determines success. It's actually all the things you do that collectively determine success. Yes? Well, it'd be better if I could kind of get the mode out and then we'll start. But I see the time, so we've got to move quickly. Okay, so let's move on. Another kind of critical point about healthcare delivery is that, and this is really important for you all to understand, volume matters. If you only have one case a week of something, you can't deliver value. If you have, you can try hard, but you can't deliver value. You need a certain minimum number of patients to be able to afford to have a team that's really dedicated to serving their needs. You need a certain minimum volume of patients in order to have the right facilities to actually serve that patient well. So volume matters. And right now, we've got a hyper-fragmented system. The ethic in medicine is, oh, I can handle anything. We'll take care of anything. Every community hospital pretty much tries to do everything. And therefore, they don't have enough volume in order to do it well. This is Sweden. Sweden we think of as nirvana in healthcare because, they have universal insurance, universal primary care. But look at some of the data that's got the Swedes really upset and anxious. This is the number of cases per week that the average Swedish hospital cares for in a particular, in a series of particular areas. And, let's just take the one on top, knee procedure. That's total knee replacement. One admission per week. Now, a good knee surgeon can do 7 of these in a day. One surgeon. So that means that if you have one case per week, what's your surgeon doing? Your surgeon's doing 25 other kinds of orthopedic operations. Now, in a good total knee unit, in the operating room, there's no need for the surgeon to talk to the other people that are in the room. Everybody knows what they're doing. They do it over and over and over again. They're a well-oiled machine. But what happens when you're doing a knee one time and a shoulder the next time and a laparoscopic procedure the next time, it means that you're going to be ineffective and inefficient. You're going to have a lot of complications. You're going to have a hard time building kind of that well-oiled team that's going to allow you to double or triple your productivity. So one of the problems in healthcare delivery is we've got to make sure that we, where we have complexity of services, that we have enough volume. And that's going to require, again, a new model in many systems. Measuring outcomes. Outcomes are really fundamental to understanding how well the team does in terms of the health of the patient. Right now, in measurement, we're focusing mostly on the processes. We're measuring compliance. We're measuring whether the physicians actually follow the compliance with the evidence-based guidelines. That's certainly a good step, but ultimately what will need to happen in healthcare is we're going to have to learn to measure the outcomes themselves, how well the patient does. And outcomes are inherently multidimensional. You know, did the patient survive is certainly an outcome, perhaps the most important outcome, but how healthy did the patient get? What functional status was actually achieved? How fast was the recovery? How many complications were involved in actually the recovery process in terms of discomfort and adverse effects? How long did the patient's health how long was it sustained before there was a relapse or a recurrence or an additional complication later on? Right now, we're flying the airplane with no instruments. Most medical teams don't know how well they're doing. They can guess, and of course they're in Lake Wobegon where everybody's above average, but we don't really know. And if we don't really know, it's very hard to actually improve on many of these fundamental outcome metrics. We have measured outcomes systematically in at least two areas in America. One is organ transplants. Every organ transplant in America involves a systematic outcome measurement. Every center in America has to report its outcomes on every single transplant. Why is that? Because to get an organ to transplant, you are required by law to measure your outcomes. It turns out that measuring outcomes isn't that expensive. It didn't create a revolution. It wasn't extremely complex. They figured out how to do risk adjustment. And guess what happened to the outcomes in organ transplants over the last 15 or 20 years? They've dramatically improved for everybody. The whole curve has gone up. The gap between high-performing and low-performing centers remains, but the whole curve has moved up because everybody kind of knows how they're doing. Everybody kind of knows that they better revisit. They better go talk to somebody else and figure out how they're doing it better. But until we start measuring outcomes, we have lost our most powerful tool for improving value in healthcare. And measuring cost is an equally great priority. What's bundle reimbursement? Bundle reimbursement is a total package price for the care cycle of a medical condition, including the responsibility for avoidable complications. So essentially, if you're getting a bundle price for a knee replacement, you'll get a price that includes the pre-surgery visits, the actual procedure, and then all the rehab until a certain point after, 3 months later, 6 months later. A bundle price means that if you have an infection, then you, the provider, have to bear the cost of dealing with that infection. You don't get more money if there's an infection. Now, sometimes there's unavoidable complications. There's things that nobody could ever predict. Good bundle pricing systems have a way of dealing with those so that you're not penalized for those. A good bundle pricing system is severity adjusted. A complex total knee with a 75-year-old gets a different bundle than a kind of a simple knee for a relatively younger, healthier patient. We now have sort of dipped our toe a little bit in bundle payment, payment for short episodes. That's what a DRG is. But until we ultimately start paying for the whole cycle of care, we create a real disconnect with value. And there are many bundle pilots going on as we speak. There's a tremendous movement in this direction. those of you that are in medicine, by the time you really get well into your professional career, this is the way you're going to be paid. Because it's the only way that we can actually align everybody's incentives. But it's a complicated thing to work out, and there's lots of details to be learned about. And this is something that all people in the healthcare field are going to need to understand and learn how to do because, again, I think it's inevitable. It's already happening. Integration of provider systems, I think, is intuitively pretty clear. Growing excellent providers across geography. Here's an example from CHOP, Children's Hospital of Philadelphia, normally #1 ranked pediatric hospital in America. CHOP has a main campus right next to UPenn Hospital. Many of you probably know that area. But you may not know that CHOP also has a large network of other units that actually deliver pediatric care. Some of them are inpatient units. Those inpatient units tend to be inside of a community hospital, but actually CHOP is running that inpatient unit. It's CHOP physicians and CHOP staff that are actually managing that inpatient unit, even though it's in a community hospital that's not part of CHOP in terms of ownership. They have a variety of, and that's represented by these hospitals. These are all inpatient units for both newborn care and pediatric care that CHOP staffs, even though in most of these cases they don't actually own the hospital. There's another set of probably 25 or 30 outpatient units, some primary care, some specialty care, that are spread all over the tri-state area that actually CHOP is managing itself. So to go to CHOP, you don't just go to the downtown hospital. You can get CHOP quality in a huge tri-state region. And what's very exciting about this model at CHOP and why we wrote a case on it is that the care in all these units is actually connected. It's not that each of these units is kind of a standalone thing. These units are all really part of an integrated organization, so that if a kid needs a certain kind of care, they can get it in the outlying community hospital. But in a serious case, there's a seamless transition to get that child to the more acute facility. There's a kind of a sense that this is an integrated network that's getting the patient to the right place to get the right kind of care as part of an integrated process. This is still very rare. Most hospital systems are not hospital systems. They're just collections of independent hospitals that are often very balkanized and separate. And then finally, information technology is a critical piece of value-based delivery. This slide, and by the way, these slides will be posted so you can look at them at your leisure. This slide kind of talks about what are the characteristics of the kind of IT systems that we actually need in order to enable a very high-value model. Some organizations are getting closer, but we still have a long way to go. And probably the #1 constraint right now is standards. We don't have clear enough standards to be sure that we're all talking the same language, that we're all defining things exactly the same way, that we're measuring things with the same number of significant digits. And therefore, the systems still are not really able to talk and compare and aggregate data effectively. That day is coming, but the task is still far from completed. Now let's talk a little bit about global health, and then we'll open it up. So if we go from America or Sweden or Japan or Germany, and we start thinking about Rwanda or Brazil or Peru, how do we kind of take these basic ideas and kind of adapt them and think about them in these resource-poor settings? And clearly, a resource-poor setting is different. There's less resources. The patient is in a fundamentally different situation than in an advanced economy. But what has been very surprising to me and to our colleagues in the Global Health Project at Harvard is just how many of the same issues apply to global health as apply to the more general questions in advanced economies. We have in global health the tendency to think that the product is treatment, that if we provide the ARV drugs, then we've succeeded, rather than to understand that the problem is health. It's how well the patient actually does. So many global health projects measure success based on volume. How many screenings, how many tests, how many drug prescribings occurred, rather than actually the value of the services provided. How well the patient actually did. We succeed if we get the patient on ARVs, but we don't really know whether the patient had a good outcome, because we don't even measure it in global health, just like we don't measure it in advanced economy settings. In global health, there's a tremendous pressure to think in terms of interventions. Many NGO programs and other programs in global health are organized around individual interventions, rather than thinking about really the whole care cycle for the patient. There's a tendency to kind of look narrowly at individual diseases, the so-called kind of vertical view that we need to think about malaria, rather than to understand that many diseases are really interconnected. And so the medical condition is not the narrow disease, it's kind of a set of related diseases that tend to occur together. And probably the most debilitating thing of all is that global health is massively fragmented. And the advent of NGOs and lots of money has just made the problem worse. We have hundreds, if not thousands, of standalone programs, each of which is reinventing the wheel. People are passionate, they care, they're working hard, but we have these little programs that are completely disconnected with each other. And they're not part of a system. And they're not operating at anything like the scale necessary to actually be particularly effective. So we have a very similar set of problems, ironically, despite the very different setting involved. So this is just a picture that Jim Kim, my co-author in this area, found. And this is just one country and all the stakeholders and the entities involved in the delivery system in a country like Tanzania. And this doesn't even include all the hundreds of other organizations actually delivering care. We're not looking at this as a delivery system. We're not looking at it in terms of integrated care. We've got to learn how to do that. So as we have been doing case studies and working in this area, we've come to believe that at least at the broadest level, global health delivery systems need to start kind of being designed and developed with a set of fundamental principles that really involve kind of four basic sort of analytical levels. One is the whole notion of the care delivery value chain for individual medical conditions. When we think about HIV/AIDS or malaria or mother and child health, we've got to think not about the interventions, but we've got to think about the whole delivery systems for dealing with those diseases. As we deliver care in resource-poor settings, however, we are going to need a shared delivery infrastructure in which we can actually deliver care, but in a setting where we're going to have to take advantage of the efficiencies of scale and utilization that come from sharing infrastructure across multiple diseases. So how do we design that shared infrastructure in order to be a good platform for the actual care delivery itself? Of course, in global health, a fundamental issue is aligning the design of the delivery system with the external context facing the patient. The patient's access to transportation, the patient's nutritional status, the patient's family and kind of social norms and stigmas and so forth. In global health, it's even more important than it is in advanced economies to kind of recognize that the circumstances facing the patient actually have a fundamental impact on the actual design of the right way to deliver care. And then, and this is something I've been particularly focused on myself, how can we actually, as we design delivery systems in resource-poor settings, how can we design systems that not only provide health care, but also maximally leverage economic and social development in the communities in which these systems are operating. We tended to see there to be a competition between economic development and health system development. We've tended to see these as competing priorities for resources. I think what we're coming to understand is actually they're extremely synergistic, and that we can leverage our health system development to very, very good end for economic development if we kind of understand where those leverage points are. Now, in terms of the first level of thinking, I think this is a very busy chart, but this is really the care delivery value chain for HIV/AIDS. And what this says is that in dealing with HIV/AIDS, we can't just think about a screening program. We can't just think about a ARV program. We can't just think about, clinical deterioration programs or hospice type programs. We've got to think about these things systemically as sort of a set of interrelated activities and interventions. And this is a process of research and experimentation that is just underway. We now have about a dozen case studies of the best HIV programs we can find around the world. And what we're starting to understand is that the best programs are ones that have been able to kind of get out of the silos and think about how they can actually provide much more effective care by thinking more across the value chain rather than just see themselves as just doing one isolated and discrete step. Again, the time does not permit me to kind of delve into the details of each of these areas, but let's just talk a little bit about why you need to think about the whole value chain, not just about the individual interventions. Here's just four examples. Yeah, what we know is that if we're going to do prevention well, we can't think about prevention as sort of a generic task. We've got to think about prevention in the sense of who's actually at risk. You don't create value by doing some preventative step to somebody who's not at risk. The way you create value is you figure out who's really at risk and putting your resources for prevention in a very surgical way against those people. That's kind of an example of kind of how value thinking might affect what we actually do in practice. Early diagnosis helps not only for its own sake, but it also helps in actually forestalling the progression of the disease. So if we can diagnose early, we get a benefit downstream. We get a benefit because we don't have to really start the expensive therapy until later if we manage the patient well. How we do something earlier in the process affects us later in the process. Intensive evaluation and treatment at the time of diagnosis can forestall disease progression. It may seem expensive to treat somebody that doesn't have, that doesn't need drugs. And we just leave those people to wait until the time that they need drugs. But it turns out that if we do treat them, we can create a lot of value because we can really stretch out the period before extensive drugs are necessary. And another kind of classic example of value thinking is if we can get compliance to be very high for the first stage therapy, we can avoid the need to go to a much more costly second stage therapy. So we would be willing to invest a lot in compliance because it's going to save us a lot of money later on in the process. So things like community health workers may be a real bargain because the community health worker who can watch that patient actually take the drug and make sure they have it and make sure they comply will save us the need to pay for a 5 times or 10 times more expensive course of therapy later on. Again, that's kind of value thinking. But when we're organized around interventions, when we're measuring success based on volume, not value, we miss those critical points. Now, again, we could talk about this sort of analytical mindset at all these levels. How we design the shared delivery infrastructure to kind of maximize value. How do we integrate the horizontal and the vertical in a way that creates the best possible outcome per dollar of cost? Again, some implications just taking HIV/AIDS. What are the relevant aspects of external context? What are those things that are going to affect our success in actually caring for patients and providing care? And what do we know about the best possible way in which to deal with these various factors? There's a tremendous amount of knowledge about this in the global health field, but it's never been pulled together. This is a field of lots of little papers on lots of independent subjects, and there's been really no way of kind of aggregating our knowledge about all of these things and transmitting that knowledge to practitioners in the field who have to figure out how to design their systems and actually provide care in a highly imperfect world with limited resources. So how can we kind of start to accumulate our knowledge base about each of these factors and how to best deal with them? Again, here's some implications, again, for the case of HIV, where we've done a lot of work on that. And then, of course, the impact on economic development. I think it's well understood that healthier people are necessary for a productive economy. I think we all understand that. If people aren't healthy, they can't work, they can't be productive, they can't create a benefit to the economy. But what is less understood is how the health system itself is a driver of economic development through the direct employment, but also through the procurement and through the catalytic effect that the health system can have on the kind of critical infrastructure necessary for enabling economic development in poorer settings. And this is, since I'm an economic development scholar as well, this bridge between the health system and the economics development is something of particular interest to me. Again, there's material written about this that we can share with you. Now, a lot of the thinking in global health has been on public policy. What's the right public policies that will move the health system forward? But I think we've often gotten the cart before the horse. We really lack a shared understanding of what a high-value delivery system is in a resource-poor setting, what it would look like, how these elements interrelate, what the role of the various clinics and hospitals and other institutions is, how to see this as truly a system. Until we understand what a high-value system looks like, it's pretty hard to set public policies that are actually going to work and drive us towards our goals. So we believe very strongly that we need to add another level to the research and ultimately to the practice in this field. We've got a lot of work going on basic science, and that work hopefully will continue, and hopefully we'll have more breakthroughs and more progress. And people like the Gates Foundation are pumping billions of dollars into basic science to kind of improve the tools available. There's a lot of work in healthcare on clinical science, on what's the proper diagnosis, what's the proper intervention, how do you think about that, how do we learn how to do that better. They're really, really important. There's a whole established literature around clinical trials and other methodologies for doing this work. There's a growing body of work in evaluation science. Does this intervention work? Is it cost effective? Unfortunately, a lot of that work, though, is kind of not very connected to reality because it's controlled experiments. It's holding a lot of things constant and varying only one thing. And we know that in real life, everything's always varying. And we don't have controlled experiments. And so we need to learn how to deal with the complexity of the actual delivery. So we believe that there's another body of work necessary, which is what we would call delivery science, which looks at some different kinds of questions. How are interventions best delivered? What do we know from the many organizations in the world that are trying to do this? How do we know which ones are most effective, which approaches are most effective? Not a field in that area yet. How can the whole set of interventions be integrated over time? How do you put these things together? How do you really adapt delivery to specific kinds of local circumstances? What do we know about that? And then, of course, how do we measure value? Not just how many drugs were prescribed or how many patients were served, but actually how well the patients did. And how do we develop new techniques and methodologies for doing that? As I mentioned before, we have a project at Harvard called the Global Health Delivery Project. We have a tremendous body now of case studies that you might be interested in. These are the organizations that now have in-depth, on-site, clinical, deep studies done of what did they do and how is it going, which allow us to really dig into what creates effective healthcare delivery models. How do you organize? How do you reward the workers? How do you best reach out and engage patients. There's a wealth of learning out there, but we've never had a mechanism for pulling it together. So our hope is that some of you that are passionately interested about global health will kind of tap into this work. If you're interested, become part of it. We would love to have a bunch of people at Yale working in this area as well. We'd love to share all we have with you because global health has been a field where there's been a lot of passion and people have viewed with have a tremendous desire to do good here. And it's been a field where kind of, let's call it, values have been very important. We have an obligation to help people in resource-poor settings get health care. But, Jim Kim and I, in particular, my co-author in much of this work, we think it's time to move from values, we care, to value. We're really creating great outcomes efficiently. And that's kind of the place where we think this field is kind of needs to move in the future. So hopefully some of you will be moved to read some of this material, get in touch with us, and we'll look forward to that.